All right, good afternoon. I'm going to get started a little early today. I did say last week that we're going to be starting at 1 o'clock. Probably going to go maybe even a little bit further than 3 today. We'll see how things go. I just want to tell you kind of what's going to be happening over the next 3 days. We're going to review the bones and go over the bones that will be on the first competency, which will be on the Thursday of week 2. Hopefully we'll finish either that up today or early tomorrow. Then we'll get on the muscles, go through the muscles, and give you a reminder of what will be on the competency. And again, go through the important origins, insertions, actions, and innervations. Probably be doing that tomorrow and most of Wednesday. And then at the end on Wednesday, I'm going to kind of give you an idea of what's going to be happening on day 1 on January 11th, what we're going to be doing. You guys, again, will be coming on campus on Monday the 11th. Also, please remember that on Monday the 11th, you will be expected to have your required books with you, which will be the Giles study guide and the trail guide book. So those will definitely be required. Please remember that you will also be required to when you come onto campus, but day 1, you will be required to wear your blues. All right. So please, if you haven't gotten them yet, please come onto campus during the vacation. The bookstore will be open. If you're not sure, just give the campus a call. This way you can get in contact with the bookstore. You're going to need that stuff because unfortunately, I can't let you into class unless you have this. So again, there is 4 weeks. You have this, the rest of this week, and 3 weeks of the vacation. So again, by the 11th, you should have everything that you require. When I send out today's video, I'm also going to send out the final required books and recommended material that for the class. I'll give a synopsis of what you'll need for this month, definitely, what I recommend for this month, and books that I don't recommend that you don't buy until at least month number 2, until the kinesiology class. So that will be in the email that I send with the with today's video. All right, so I'm going to begin. So let me get to the shared screen. All righty. I did make some changes to this PowerPoint. This PowerPoint will be on Blackboard on day 1. So the changes will be quite evident. What I did was I added the muscles that will be on these specific bones, their origins and insertions, and we'll kind of go over them. So let's start on the bone review. So the skeletal, again, the skeleton, what you want to do with the skeleton is you want to see where all these bones are articulating. And when you hear the word articulation from us, it's bones and muscles that are together. They articulate with each other. They are together. So, understanding that the clavicle articulates with the sternum and articulates with the scapula is important to know. Understanding that the distal portion of the humerus articulates with the radius and the ulna are important. So you need to understand when we're looking at each bone and each landmark, how they work together and how they, how they articulate with each other. So understanding the how the skeleton is very, very important. Good afternoon, Ashley. I just started a little early.
Oh no, you're totally fine.
So when you check out the video, I kind of go through what the rest of the week is going to be.
Perfect.
You didn't miss much bone wise. So
Awesome.
what you'll see with this PowerPoint, though, you'll see a couple of differences in it. I added some things to it. I added the muscles that articulate with these bones, so that you will see added to it. So like I was saying, understanding how these bones articulate with each other is very, very important. Again, the overview of the skeleton, we basically have two regions. We have the axial skeleton, which in this picture is the tan portion of the skeleton. And when we're looking at the axial skeleton, it's the central supporting axis of the body. It's basically the center point of the body. And we also have the appendicular skeleton, which are basically the bones and muscles of the upper and lower limbs. Good information for you to know that there's 206 bones in the body. We do have some special bones known as sesamoid bones. The patella is one that you will know. In the wrist, the pisiform is a sesamoid bone. And basically all that is a bone that forms within a tendon. At birth, there's approximately 300 bones. And basically, as we get older and increased weight bearing, these bones begin to fuse together, giving us our 206 in total. A lot of these bones, again, have these really important surface markings. We call them landmarks. So you will see many ridges, spines, bumps, depressions, canals, and all of these are very, very important. So when we're looking at like the humeral head has tubercles which extend outwards, which allow certain muscles to articulate with those portions of the bone. Again, the axial and the appendicular skeleton. In the tan portion of this picture is the axial skeleton. We're looking at the skull, the vertebra, the sternum, the ribs, the sacrum. The hyoid bone, which is a bone that we're not too concerned with as PTAs, but no, if the hyoid is fractured, it's pretty much leads to death. The appendicular skeleton is the portion of the skeleton that's in the green. It's, again, you'll see the limbs, the legs, and the arms are in the green. The clavicle is in the green. These are important struts and important parts that lead to the appendicular or the upper and lower limbs of the body. The cranial fossa, not part of that we will need you guys to know, but know that the cranial fossa, which basically makes up the top portion, is basically where the brain is held. And in the brain, we have a frontal lobe, a temporal lobe, the cerebellum. And all of these lobes are important, more towards the neurosection when we talk about the neuro portion of this class, and then in future classes, we'll be talking about the importance of the cerebellum and how the cerebellum is all about the balance in the body, and that's something we are definitely concerned with as PTAs. So the first bone that you will need to know will be the frontal bone. The most important thing that you need to know for us is that it forms the forehead and part of the roof or the cranium of the skull, and it's this portion right here, right in the front, right above the eye orbits on the skull. That is the frontal bone. So when I put a number on that, all you'll basically have to tell me is that it's the frontal bone. The parietal bone is directly behind the frontal bone. In this picture, it's the bone in pink right here. There are two parietals, one on the left side here. So here's the left side, and let's just say, and here's the right side. Here's the frontal bone right here. So the parietal bone is directly behind. Basically, it forms the rest of the roof of the skull, and it also forms a portion of the lateral wall of the skull. Again, it'll be much easier to see it when you have the bones in front of you. The temporal bone is this bone right underneath the parietal bone. It's the lavender portion right there. It has a couple of different landmarks that you will need to know. And you'll notice that I do have those portions highlighted here. The zygomatic process is this zygomatic arch right in this area here. The external auditory meatus, let me clear this picture because is this hole right here. It's the ear hole. The external auditory meatus, you'll need to know that is part of the temporal bone. You'll need to know it because in the students today, we're doing goniometric measurements in one of the classes. So when we explained how we do a goniometric measurement of flexion and extension of the cervical portion of our body, one of the landmarks we use is the external auditory meatus. So one of the students actually came to me and said, okay, now I understand why we needed to know that. And you need to know it as the external auditory meatus. It's not the ear hole. So please understand that if you were to say that's the ear hole, that would be incorrect. It is the external auditory meatus. Right here, this projection that's coming out that looks like a needle is known as the styloid process. Again, that is also part of the temporal bone. And finally, this bump that is on the back portion of the temporal bone is known as the mastoid process. An important landmark because there's an actual muscle that articulates with the mastoid process, and that is the sternocleidomastoid bone. So, and that is a muscle that you will need to know. So here's the screen that one of the screens that I added on the mastoid process. The sternocleidomastoid has its insertion. So when you see these muscles, you'll either see an O or an I next to it. What this means in this case, that the insertion point of the sternocleidomastoid is on the mastoid process of the temporal bone. All right, so I added the muscles that go with it to hopefully help you with your studying. This will be on Blackboard. I'm not going to send it now. I'd rather you guys just know the bones, and then when we get into class, we will really bring it all together.
Do you know when Blackboard's going to be updated? Like when we can start seeing the class?
You won't be able to see the class until the Sunday before it.
Okay, that makes sense. Okay.
Yeah, they don't allow you guys to see it until the Sunday before any class. It's one of the things we've tried to change, but hasn't been. They won't allow us to do that. So, but I've already sent you guys the first week of lectures. I've sent you the bones, I've sent you the muscles, and the vocabulary with planes and axis and movement. So you guys already have more information you have a lot of info to go through. So you guys are actually in pretty good shape information wise. Yeah, the class won't open up to you guys until 12:01 on Sunday before the class. So again, hope that answered your question, Ashley. I apologize. So again, on the temporal bone, on the mastoid process, sternocleidomastoid sits and has its insertion on that bone. The occipital bone is the bone in the posterior portion of the skull. It's this portion in green here. You won't need to know, the only reason I would put the skull in this position was to talk about the foramen magnum. When you guys see it on your practicals, I'll show it to you from the other side of the skull. You won't be looking at it from this side. Two of the landmarks that you will need to know on the occipital bone is the foramen magnum, which is the portion of the skull that allows the where the brain basically turns into the spinal cord, and the spinal cord goes through the foramen magnum in the skull. The second portion of the occipital bone that you'll need to know is the external occipital protuberance. Now, the external occipital protuberance is that small bumpy area on the posterior side of the occiput. And this is an important landmark because this is where the upper trapezius muscle has its origin. I do know I have on there the nuchal ligament. Remember, I spoke about that ligament that excuse me, that extends down the cervical portion and allows for more surface area for muscles to articulate with it. But the more important information that I need you to know for the external occipital protuberance is that it's the bony landmark that is the origin for the upper trapezius muscle. Okay, remember we spoke about the trapezius basically is made up of three parts: the upper trapezius, the middle, and the lower. Well, the upper trapezius has its origin on the external occipital protuberance. All right, so there won't be any worry about that. The only zygomatic bone that you will need to know is the zygomatic arch, which is part of the temporal bone. Much easier to see on the skull itself. It basically looks like an arch, and if you palpate the bony structure underneath your eyes and go backwards towards the ears, the part on the side is where the zygomatic arch sits. And basically it looks exactly like, it looks like an arch. All right, it looks like an arch. So again, once you see the skulls live and in person, you'll be able to make out the zygomatic arch quite easily. The other part of the skull that you'll need to know is the mandible. If you look at the bottom of this slide, the mandible is there. I'm going to show you another picture next. The mandible is the one part of the skull that does move. It's the opening and closing of the mouth. It is the strongest bone of the skull. Again, that's just basic information, not information that I will put on a quiz or a test. I'm going to need you to know the parts of the mandible. Now, all of these landmarks are on each side of the mandible. So the ones that you need to know, you'll need to know the body of the mandible. So let me get my little pen out. So the body is basically this area here, from here to there. All right, so the body of the mandible. All right, I'm going to skip the angle for a second. The ramus of the angle is this part on the posterior portion. All right, so you'll need to know the body and the ramus. The angle is where the body and the ramus meet. Basically, the angle is that little small circular portion. So to start off with, you'll need to know the body, the angle, and the ramus. On the upper side, this area is where it articulates with the skull. I'm going to need you to know that the condylar processes, which is right here, and this portion right here. All right. And then above the posterior condylar process is the mandibular condyles that actually articulate with the mandible, and that part actually forms the temporomandibular joint. The other part I'll need you to know is this notch area. So this half an O. So the mandibular notch. So again, for the mandible, you'll need to know on your practical, you'll just need to tell me that it's the mandible. But on the exam, on my quizzes, I'm going to ask you about the body, the angle, the ramus, the mandibular condyles, the coronoid processes, and the mandibular notches. So those things I will ask you on the quizzes. All right. The vertebral column. On this slide, I am going to want you to know the functions of the vertebral column. It's important. You need to understand that the vertebral column supports the skull and the trunk. The spine allows for the movement of the vertebra. These vertebrae move, allows us to flex, extend, and laterally rotate and laterally flex our back. So there is a great deal of motion that occurs there. The vertebral column is protection of the spinal cord. The column itself as a whole absorbs stresses and allows forces to go up the spine to the stronger parts of the bone. And it is an attachment point for like the ribs and for postural muscles that actually articulate between the vertebrae themselves. So again, the information that I'm going to need you to know on this slide, I'm going to need you to know the functions of the spinal cord, of the vertebral column. The information on the bottom is good information to know, that the intervertebral discs are really, really small. And remember, the intervertebral discs are in between the vertebra, basically from C2 on down. Good piece of information that actually a person is shorter when they go to bed than when they wake up. When they wake up, they're a little bit taller. And the reason is because there is water or fluid that is imbibed by the intervertebral discs within the nucleus pulposus, which increases the size of those discs. And the younger, more healthy folks, well, you wake up a little bit taller than when you go to bed. But as we get older, this imbibing of the intervertebral discs become less and less. Hence, that's why as older adults, we start to look a little bit shorter because that fluid is actually not getting into the intervertebral discs. Like I said on the bottom here, compression or walking squeezes the water out during the day and absorbs the water during sleep. So again, you're shorter when you go to sleep. You're a little bit taller when you wake up. Nice piece of information for a family when you guys return to the Thanksgiving table next year. Information that I will not put on the tests, that you have 33 vertebra. It's broken up into 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal bones. So it comes out to 33 in total. Again, not something that I'm going to put on any kind of quiz or test. The primary curve, and the primary curve is seen initially in our children, in our babies, in our newborns, where there's one continuous curve. So you could see in this picture that the child's spinal vertebra is basically shaped in one whole C curve. That is known as the primary curve. Now, as we get older, that primary curve sticks around with some parts of the spine. So that primary curve is present in the thoracic area right here. So you can see the thoracic area, and in the pelvis area right here, that primary curve sticks around. It looks like a C. So as we get older, the primary curve is present in the thoracic and pelvic regions. But as we get older, we develop these secondary curves. As you can see, the cervical curve right here and the lumbar curve right here go in different directions. And they develop cervically because when we are able to hold our head up, that curve changes shape. And once we start to stand and walk, it develops the lumbar curvature. All right. So our primary curve actually does stick around with us through life in the thoracic and pelvic regions. But as we are able to pick our heads up, it changes the curve in the cervical area. And as we walk and put weight through our lower extremity, it changes the curve in the lumbar area. Now, these abnormal curves, so as you can see here, this here is a normal curve. We have a inwards curve cervically leading to an outwards curve thoracically, an inward curve at the lumbar area, and the pelvic region has an outward curve. This is what our spine looks like normally, right? This is our normal curvature. But when we have certain diseases, when we have poor posture, when we have congenital defects, and even when our ladies become pregnant, the curvatures of our spines can change, and they can change to be quite, quote unquote, abnormal. So if you look at these pictures, you're going to see a green line and a red line. The green line is what the normal curve should look like. The green line is what the normal curve should look like. The red line is an abnormal curve. And I'm going to need you to know the difference between these curves, all three of them. I can tell you, and I will tell you because I'm a nice guy. How you doing, Jean Carlos? Good to see you.
Good to
I
see you.
can tell you, I made up the quiz on the second day quiz this weekend, and I put this on the test. So I'm telling you it's on the test. All right, I can't be more clear about it. All right, it's on. This is on the test. I'm not going to tell you what it is, but I'm telling you that this slide is on the exam. Could be 1, could be 2, could be 3 questions, but it's on it. So I need you to know the difference between these curves. A scoliosis curve. This is a lateral curvature. So if we look at the first picture, we see how the curve in red here goes down and then comes out to the side and then returns back. All right. A scoliosis usually occurs in children. The scoliosis is a very common curve. This curve is usually seen in the thoracic area. And I'm not going to question you about concave or convex. What I am going to question you on in relation to these curves are basically the definition of these curves. A scoliosis is a lateral curvature. All right, it's a curve going laterally. It could go laterally to the right. It could go laterally to the left. It all matters on which way the pressure is. A scoliosis is a lateral curvature. And again, the scoliotic curve is a curve you will see usually in children. All right, usually seen in children. We can fix it if it's taken care of early. If it's not taken care of early, the curvature can become very, very bad, and a surgery could be required. The second curve is a kyphotic curve. As you can see here, a kyphosis is a form of hunchback. Remember the movie, The Hunchback of Notre Dame, or Notre Dame, was a small man. He was all bent over, but he had this large hump on his back. That is known medically as a kyphosis. A kyphosis is an exaggerated thoracic curvature. It is a hunchback. All right. It's usually seen in our elderly. All right. And it's women more than men, but a lot of young weightlifters get it also. But our elderly usually get it from osteoporosis or osteomalacia, weakness of the bones. The third type of abnormal curve is known as a lordotic curve. Now, as you can see right here on number 3, the green has a very slight curve. We have a natural lordotic curve in our lumbar area. But when that curve becomes exaggerated, becomes severe, as you can see in red here, that red has much more of a curve. That is a lordotic curve. So we have a normal lordosis, like in green, but when there is too much of a curve, it is known as an exaggerated lordotic curve. And you will see this usually in overweight or obese people, or our ladies who are pregnant. And this is what happens. So let's take this lady right here. She has all her weight up front because she has a child. What happens, let me kind of clear this a little bit. She has all her weight up front here. All this weight is pulling the back muscles forward, all right, creating this very exaggerated curve, very, very exaggerated curve. So our pregnant women, when they say they have back problems, this is one of the reasons why, is because they have an exaggerated lordosis. So for this slide, I need you to know the definitions of each of these abnormal curves. I can promise you it is on the quiz, and I can literally tell you it's on the quiz on the second day. So you even know when it's going to be. The vertebra, well, it's made up differently at different levels. The cervical vertebra are different than the thoracic, and the thoracic are different from the lumbar vertebrae. But there are certain parts that they all have in common. So they each have a body, all right? They each have this area back here, basically except C1 and C2. C1 and C2 doesn't have that body, have this body right here. But each of the vertebra has that body in a different way. The cervical vertebra that has a body has a very, very small body. The thoracic vertebra, their body is bigger than the cervical, and the lumbar body is bigger than both the thoracic and the cervical. So it's a good way of telling the difference between the vertebra is how big is the body compared to other ones. There is a vertebral foramen, which is the hole right here where the spinal cord goes through. That's pretty darn easy. The vertebral arch is very, very important. The vertebral arch is made up of the pedicle and the lamina. All right. The vertebral arch is made up of the pedicle and lamina. Now, the lamina is the area from the spinous process to the transverse process, this area here. The pedicle is the area from the body to the transverse process. Together, they make up the vertebral arch. On almost every vertebra, there is a transverse process. Transverse meaning on the side. So these bony projections on the side are transverse process. They extend laterally out to the side. All right, those are quite important. Let me clear this because right here is an area known as the superior articular process. So you can tell this one right here is the superior, but on the bottom there is an inferior articular process, and it's this area where the vertebra meet. And we'll talk about that in the next slide, because where they meet creates another foramen, creates another hole where the nerves actually come out. On each of these articular processes are facets, and these facets are smooth material cartilage. They're hyaline cartilage that allow for movement to occur. Remember, I said that one of the functions of the vertebra is to allow for movement. Well, that movement comes at the superior and inferior articular processes because of that hyaline cartilage known as facets. We'll go a little bit more into it in another slide, but as you can see on the bottom picture is a picture of the intervertebral discs. Between each of the vertebra are these discs which allow for cushioning and allow for absorption of forces. Thankfully, you're not going to need to know too much about it now. The information I'm going to need you to know is that the middle portion is the portion where there's a great deal of water and fluid, and that is known as the nucleus pulposus. They call it a pulpy section. All right, the nucleus pulposus is the center of the intervertebral disc, and surrounding the nucleus pulposus are these rings, these cartilaginous rings, and they're known as the annulus fibrosus. So whenever you hear that somebody herniates a disc, what's basically happened is that the nucleus pulposus, the fluid within there, has broken through those rings and are most likely on the outside of the intervertebral disc itself. Now, this slide basically gives you the difference between these vertebrae. I can tell you again, this is going to be on the quiz, all right, and how to tell the difference. Again, when we look at the body, well, the body, you can see the lumbar vertebra on the right. Well, the body is much, much bigger than the cervical vertebra on the left. The spinous process, which is on the posterior side, well, they're different too. On the cervical vertebra, we have that bifid spinous process. It's short and has two portions. The thoracic spinous process is very distinct. It's very sharp looking, but it has a downward projection. If you look on the bottom of this picture here, here's the spinous process right here of the thoracic vertebra, and you can see how it projects downward. The lumbar spinous process is very short and blunt, very thick looking. When we're talking about the transverse process, well, the transverse process are very different. On the cervical vertebra, there's a foramen on there. the transverse foramen, where the arteries and veins go up into the brain and bring blood and everything else needed to survive for our brain. That is, the thoracic and the lumbar do not have that. Do not have that at all. The when we're looking at the thoracic vertebra, that's the only vertebra that has the costal facets. Remember, I said that it's only the thoracic vertebra that have an articulation with the ribs, right? With the main ribs. So most of them occur at the thoracic vertebra. So those are some of the ways that you can differentiate between the cervical, the thoracic, and the lumbar vertebra. And those will be questions that I will ask you. So getting to understand this slide is going to be a good thing. Remember, I said that the two vertebrae, we have one vertebra on top of the other vertebra, and they articulate with each other. Well, when they articulate with each other, they create a foramen. And this is the foramen right here. So here's L1 and L2 articulating with each other, and it creates this little hole on the posterior portion, all right? Basically right in front of the spinous process. The intervertebral foramen between vertebra is an opening for the nerve fibers to come out. That's where the nerve fibers come out to the arms and the legs. So this portion is very important. Sometimes, if you look here on the bottom, if you look right here, we have this area right here, and we have this yellow area. This is the nerve fibers that come out this back, come out through the intervertebral foramen. But what happens sometimes is this area right here, which is the nucleus pulposus, will herniate. And what I mean by a herniation is basically when a part of something goes into another part of something where it doesn't belong. In this case, the nucleus pulposus goes out into the intervertebral foramen and puts pressure on this nerve. So think of it when somebody has sciatic pain. Well, what's happened most likely is a herniation of the disc. The nucleus pulposus has gotten through the annulus fibrosus, causes pressure in the intervertebral foramen and putting pressure on a spinal nerve or even the spinal cord itself. And when somebody says that they have pain going all the way down the back of their leg, maybe even into their calf and their foot, well, it's because of this herniation that's occurring. Okay, so that's why there's such an important and understanding, especially for us as PTAs, at what the intervertebral disc does. Because our treatment is going to be determined by whether the herniation is it a posterior herniation? Is it an anterior herniation? Right? Because the different ways we exercise someone and stretch somebody is determined by whether it's an anterior or posterior herniation. So again, like I said about the intervertebral discs, they started C2 and C3. They ended L5 in the sacrum. They consist of the inner gelatinous mass known as the nucleus pulposus and the outer ring of fibrocartilage known as the annulus fibrosus. The intervertebral disc is a shock absorber. It binds the vertebra together and it supports the weight of the body. So it has a lot of important functions. We'll go through the specific vertebra. So C1 is the atlas. Remember, atlas in Greek mythology held the head up. Held the world up. My apologies. Well, atlas C1 supports the head. C1 has no body. All right, it has no body. All right. An important aspect of C1 is that it allows the gesturing of yes. It allows the movement of the head going up and down. Specifically, flexion allows for flexion of the cervical area. Allows for us to be able to say yes. So C1, known as atlas. C2, known as the axis. This bone allows for the gesture of saying no. It allows for cervical rotation. Okay. There is an important landmark or an important bony landmark on here that's different from any other vertebra. C2 is the only vertebra that has the odontoid process, also known as the dens. And that is this bony projection right here that sticks upwards like that. Whether you call it the dens or whether you call it the odontoid process, it does not matter to me. All right, as long as you know that C2 has C2, also known as the axis, has the odontoid process or the dens. You'll notice the spinous process here. Again, I said is bifid. Here's 1 and here's 2. Here's a really good picture of a bifid spinous process. 2 parts, bifid. All right, and it's only the cervical vertebra that has that bifid spinous process. So C1 and C2. Here's the articulation between the 2 bones, between C1 and C2. Again, you will notice here that there is a ligament that goes in front of the dens right here. This ligament right here, the transverse ligament, basically keeps these bones together. As you can see, it's only a ligament that does it. All right. So it's very important not to do damage to that area. Basically, you do damage to that area, you're either very, very paralyzed or you're no longer on this earth alive. Especially if the odontoid or dens breaks. So there is definite horrible ramifications if that does occur. Now, your typical cervical vertebra, so these are the parts specific to the vertebra. These basically are the smallest and lightest vertebra compared with thoracic and lumbar. Remember, I said that the spinous process is bifid, that the transverse process has the foramen that allows for the arteries and veins. And one other thing, C7 is known as vertebral prominence. If you feel it on yourself, you can actually feel a small bump. If you go down your neck, you could feel a bump. That bump area is C7. It is a little bit longer spinous process, and it is a very convenient landmark, allows us the ability to count vertebra. So if we know where C7 is, we can then count upwards and know where C6, C5 is, and then we can go downwards and go, and start counting the thoracic vertebra. Oops. The thoracic vertebra, there are 12 of them. Again, the important landmark here to know the difference is the spinous process. Here, the spinous process, as you can see, is pointing downwards and it looks very, very sharp. The body on the thoracic vertebra is larger than the cervical, but smaller than the lumbar. There are these costal facets at the end of the transverse processes. So right here, you can see it, right? And right here, you can see it. And these are areas that articulate with the ribs. Now remember, it's the thoracic vertebra where a lot of the articulation with the ribs occur. The lumbar vertebra, here the body is much thicker than both the thoracic and the cervical. The spinous process is They call it blunt. I would just call it short. All right. The lumbar vertebrae are very, very visual. You can definitely tell a lumbar vertebra from a cervical vertebra and even from a early thoracic. I will never show, if I was to show you on the practical, the vertebra, I would never show L1 and T12. They look close to each other. All right. They're too close looking to each other. I wouldn't do C7 and T1. Again, they're too close. So when I show you the vertebra on your practicals, there will definitely be a difference. All right. There will definitely be a difference, and you'll be able to use the characteristics that I've spoken about to where you can differentiate them. The sacrum, that's the area on the back between the two hip bones. All right, we have the sacrum area. On your practical, you will need to know what it looks like. I can show it to you from this anterior view or from the posterior view. The anterior view, this area right here is very, very smooth looking, very smooth. Where on the posterior side, it's very rough. There's lots of bumps on it. The part of the vertebra the part of the sacrum that I will need you to know is the sacral promontory. Right? The sacral promontory is the top part of the sacrum, and it's the part that articulates with the L5 vertebra. So that part of the vertebra you will need to know. What you will also need to know is that the important muscle that you're going to need to know has its origin on the anterior side of the sacrum. And that muscle is the piriformis muscle. So there are many muscles that go onto the sacrum, but the one that you need to know will be the piriformis muscle, and the origin of the piriformis articulates with the anterior sacrum. Okay, so again, this is one of the ones that I added on. So on the sacrum, the piriformis, the O means its origin. I would mean its insertion. This is very specific, is that piriformis has its origin on the anterior side of the sacrum. This is the posterior view of the sacrum. Again, if I show you this picture, if I show you this bone, all you would have to tell me is the sacrum, all right, from this view, okay? On the bottom of the sacrum, you have the coccyx. That is these small 4 bones down here at the end of the sacrum. They will be on your practical. Basically, I'll have an arrow pointing to those specific bones, and then you would just tell me that those are the coccyx bones. Now, the thoracic cage is the area where we are protecting our lungs and our other inner organs like the spleen, the liver, and our kidneys. The important part that you're going to need to know here is the sternum. You're going to need to know the sternum of the thoracic cage. So also, by the way, if you see here on the sides here of so here's the sternum itself. So you could see how the ribs attach to the sternum via these costal cartilages right here. And we do have true ribs, and we have the false ribs right here, and we do have floating ribs back here, which we will talk about. Okay, we'll talk about the ribs in a second. All right, so the sternum, as you can see there on the right, I have a picture of it. The sternum is basically protects the heart. The sternum has 3 important parts. All right, on your practical, basically, I have a structure that is just the sternum itself. That's how you're going to have to tell me about the sternum. All right, that's the sternum. On the quizzes, you're going to have to tell me the parts of the sternum and all of the landmarks. So there are three parts, there are three regions to the sternum. The top region, you have the manubrium. The middle region, you have the body. And the lower region, you have the xiphoid process. Now, each of these regions have important landmarks. So right here in whole is the manubrium. But the manubrium has a few different landmarks. Number one, the jugular notch is in the middle on the superior portion of the manubrium. You can actually feel it on yourself. Don't press too hard. On either side, right here and right here, we have clavicular notches. And that's where the clavicles articulate with the sternum. In between the manubrium and the body is basically a line. This line is where is the point where the manubrium joins the body. This line is known as the sternal angle. And when if I was to show you a picture and point to that area, you would have to tell me that that's the sternal angle because the line will be very prominent. Right underneath the manubrium, this whole area right here is the body of the sternum. The body of the sternum is where most of the ribs articulate with, okay? They have these quote unquote scalloped regions, 2, 3, they call them scalloped, okay? And so it's the body that has most of the rib articulations. On the bottom of the sternum, we have the xiphoid process. That's the inferior end of the sternum. And that's where most of the abdominal muscles articulate with, and even the diaphragm, right, which is one of our important breathing muscles. So you're going to need to know what the sternum looks like, and you're going to need to know all the parts of the sternum. The manubrium, the body, and the xiphoid process. And the manubrium has the jugular notch and the clavicular notch. In between the manubrium and the body, the sternal angle. And finally, we have the xiphoid process on the bottom. Some of the muscles that are on the sternum that you're going to need to know. So from the sternum itself, we have the origin of the pectoralis major and the sternocleidomastoid. And from the xiphoid process, we have the diaphragm. And I didn't put it, but it's actually the insertion of the rectus abdominis because the origin is actually on the pubis. So from the sternum, we do have a few muscles that do articulate with that area. The true and the false ribs, I'm going to need you to know. Ribs 1 through 7 are known as the true ribs because they each have their own articulation with the sternum. So basically, here is 1. Here is 2. As you can see, they're independent. 3, 4 right here, 5 right here, 6 right here. 7 is really close to there. Now, ribs 8 through 10 are known as false ribs because these ribs have one connection to the sternum. So ribs 8, 9, and 10 have this one connection to the sternum, where 1 through 7 have separate connections. So 1 through 7 are the true ribs, 8 through 10 are the false ribs. On the backside here are ribs 11 and 12. Ribs 11 and 12 are coming from the vertebra, but they do not articulate with the sternum. Ribs 11 and 12 are known as the floating ribs. So what I'm going to need you to know about the ribs is, A, what a rib looks like. We'll show that in a second. And you'll see it when you guys come on campus. But I need you to know the difference between the true, the false, and the floating ribs. Ribs 1 through 7 are the true ribs. They have their own connection to the sternum. Ribs 8 through 10 are false ribs because 8 through 10 share a connection, share one connection to the sternum. And ribs 11 and 12, give me 1 second, need a drink. Excuse me. Ribs 11 and 12 are floating ribs. They have no connection to the sternum. So that's the way you need to know the true, the false, and the floating ribs. Where is my picture of the ribs? I don't know where it is. All right. I thought it was on here, but I guess not. Don't know what I did with it. All right. So thankfully the rib is very, very easy. It's a half circle looking bone. On the practical, you'll just have to say it's a rib, so that you won't have to tell me any parts of it. When we're talking about the pectoral girdle, we're talking about the shoulder. Okay. We have a few bones that articulate with each other. Remember when we talked about the scapula, we talked about that the clavicle articulates with the scapula. Articulates with sternum. But as the clavicle goes out laterally, it also articulates with the scapula. All right. So there are two bones, the clavicle and the scapula. All right. And the clavicle articulates medially with the sternum and laterally with the scapula. The joint from the scapula to the clavicle is the sternoclavicular joint between the sternum and the clavicle. The joint between the clavicle and the scapula is known as the acromioclavicular joint. The acromion process of the scapula articulates with the clavicle, creating the acromioclavicular joint. The humerus bone has a head on its proximal side. The head of the humerus articulates with the glenoid fossa of the scapula, creating the glenohumeral joint. And that is the shoulder joint. The shoulder joint itself that allows for flexion, extension, abduction and adduction, internal and external rotation. All that occurs at the glenohumeral joint. And this joint really dislocates an awful lot because there's not a lot of protection there. The clavicle, it's the bone that articulates with sternum and with the acromion process of the scapula. Well, the clavicle is an S-shaped bone. All right, S-shaped bone. The rounded end is known as the sternal end. It's a rounded end. The rounded end, the sternal end, articulates with sternum. The acromial end is flat. And the acromial end of the clavicle articulates with the acromion process. This is known as a strut bone, right? Because it helps brace the shoulder and it keeps the upper limb away from the midline of the body. The clavicle is definitely the most fractured bone in the body. Just ask Tony Romo that. I know I keep going back to that. But the clavicle, an important bone that you'll need to understand. Now, there are muscles that attach to the clavicle. Even though it's small, it has some major attachments. The sternocleidomastoid. Remember, SCM also has its origin on the sternum. So sternocleidomastoid comes from the sternum and the clavicle and and has its insertion on the mastoid process of the skull, part of the temporal bone, which we spoke about earlier. The anterior deltoid has its origin on the clavicle. Pectoralis major has its origin from the clavicle, also from the sternum too. And the upper trapezius, which comes from the external occipital protuberance, the upper trapezius has its insertion onto the clavicle. Actually, the lateral 1/3 of the clavicle. Actually, the anterior deltoid and the upper trapezius both come from the lateral 1/3 of the clavicle. Deltoid and trapezius are very, very interesting. So when we talk about origins and insertions, well, the deltoid has its origin on the clavicle, and the upper trap has its insertion on the clavicle. Well, the middle deltoid has its origin on the acromion process, and middle trapezius has its insertion on the acromion process. But wait, there's more. The posterior delt has its origin on the spine of the scapula, and the lower trapezius has its insertion on the spine of the scapula. So if you ever forget origins and insertion of those two muscles, they're kind of the same. Remember, the deltoid's going to have its only insertion into the deltoid tuberosity. But the deltoid has its origins from the clavicle, from the acromion, and from the spine of the scapula. And the trapezius has its insertions on the clavicle, on the acromion, and on the spine of the scapula. So sometimes you kind of have to correlate things to make things a little bit easier on yourself. When we're talking about the scapula is a very, very important bone and a very important area where muscles are attached to. There are three sides to it. We have a superior, we have a medial side, which is next to the vertebra, and we have a lateral side, which is where the lateral side is where the humeral head attaches. I only want you to know that there's a superior and inferior angle. They call the lateral angle a combination of the acromion, the coracoid, and the glenoid. You don't need to know that that's the lateral angle. They won't call it, nobody ever calls it that. But you need to know the superior angle, you need to know the inferior angle. On the superior side of the scapula, there is a small notch, all right, which is a passageway for a nerve. That's known as the suprascapular notch, and I'll show you on the next picture. On the posterior side of the scapula, we have the spine of the scapula. Now, the spine of the scapula comes from the medial border, goes out laterally, and is actually an extension onto the acromion process. All right, so the acromion process is at the end of the spine of the scapula. As the spine of the scapula goes across the posterior portion, it creates two areas, one above the scapula, one below the scapula. The area above the scapula is known as the supraspinous fossa. It is the supraspinous fossa above the spine. And this is the area where the supraspinatus muscle sits. Below the spine of the scapula, we have the infraspinous fossa, which is the area where the infraspinatus muscle lives. On the anterior portion of the scapula, we have a fossa area there too. That is known as the subscapular fossa, and that is where the subscapularis muscle lives. on the anterior portion of the scapula. Now, there's other important landmarks that you need to know. The acromion process. The acromion process, if you feel on your shoulder, you'll feel literally a flat bone up there before you go on to the humerus. Well, that flat bone is the acromion process. It's the acromion process that articulates with the clavicle that creates that acromioclavicular joint. On the anterior side of the scapula, we have a finger-like projection. That's known as the coracoid process. A lot of people get the acromion process and the coracoid process mixed up. Remember, I said that the acromion process is an extension of the spine of the scapula. So if you were to follow the spine of the scapula laterally, the end portion of that is the acromion process. The coracoid process, you'll be able to see better on the anterior view. It's a finger-looking area, and it's at this process where we have a lot of bone that articulate with muscles. The short head of the biceps comes from the coracoid process. The pectoralis minor has an insertion on the coracoid. The coracobrachialis has the origin of that muscle on that area. The final landmark that you need to know on the scapula is probably one of the most important in the body, and that's the glenoid cavity. The glenoid cavity is a shallow socket that articulates with the head of the humerus. Well, it's here where the glenohumeral joint is created. Glenoid cavity on the scapula, the humeral head of the humerus. They articulate with each other, creating the shoulder joint. Shoulder joint is known as the glenohumeral joint. Here's the scapula. So if we look on the left on the anterior side, and you know it's anterior and posterior because the spine of the scapula right here is on the posterior side. Okay? Again, here's the spine of the scapula going out laterally. The further it goes out laterally leads to this area here. That's the acromion process right there. All right. Here on the front is this finger-looking projection. That's the coracoid process. So again, when you look from the spine of the scapula laterally, the most lateral portion of that bone is the acromion process. So let's look at the anterior side here. So this area right here, this whole area is the subscapular fossa, and it's the subscapular fossa that has the subscapularis muscle. Right here is the lateral border. I know it's lateral because here's the glenoid fossa. The glenoid fossa articulates with the humerus. Well, that's lateral. Well, this is the lateral border. Here is the inferior angle. If you were to picture the vertebra being right here, here's the medial border, which is right next to the vertebra. Up here is the superior angle. And right in this area here is that suprascapular notch, that small indent that allows for a nerve to go through. When we're looking at the scapula from the posterior side, well, again, we have the spine of the scapula right here. Remember, I said it splits up the posterior portion into a supraspinous and an infraspinous fossa. That's where these two X's are. And there's muscle, the supraspinatus and the infraspinatus sit there. Here's a good view again of the superior angle. All right, and the superior angle is where the levator scapula actually comes down and attaches to this area. Right here is the medial border of the scapula. Here's the inferior angle. Here's the lateral border right here. The lateral border has a couple of muscles that come from it. Teres major, I'm just going to put a J there. Teres major comes from here, and teres minor, I'll put an I right there, comes from here. Here's the lateral, you know, this is the lateral side because here's the glenoid fossa right there. Now, there are two landmarks that are very, very important that are not on this picture. Above the glenoid fossa, there's a tubercle. That tubercle is known as the supraglenoid tubercle. And it is where the origin of the biceps, the long head of the biceps tendon comes from. And right below it, actually it's right here, is the infraglenoid tubercle. Again, infra, below. This is the glenoid fossa right here. So below the glenoid, a tubercle is a projection of bone. Well, at the infraglenoid tubercle, the long head of the triceps muscle comes out, and that's the origin of that muscle. So the scapula is very important, and you're going to notice on the next screen how important it is, because look how many muscles attach to the scapula. These are the muscles that attach to the scapula. On the acromion, you got, like I said earlier, the middle deltoid and trapezius. On the coracoid process, the finger projection on the anterior side. Biceps brachii, coracobrachialis, and pec minor. The infraspinatus fossa, the infraspinous fossa, below the spine, is the infraspinatus muscle. The inferior angle has latissimus dorsi and teres major. The lateral border has teres minor and teres major. The supraspinous fossa is where the supraspinatus is. The medial border is where the rhomboids and the serratus anterior are. The spine of the scapula, like I said earlier, the lower trapezius and the posterior deltoid. So as you can see, the scapula is an important bone with a lot of muscle origins. And I can tell you, as a physical therapist assistant for over 20 years, you've got to know these muscles. You're going to have to know them. You're going to have to know where they come from and what they do, because you're going to be working a lot on this area. All right, because we get a lot of injuries from this area. So those are some of the muscles that attach to the scapula. The upper limb is broken up into sections. So from the shoulder to the elbow, basically the humerus, you can correlate the humerus to the brachium. Remember I said there was a muscle known as the coracobrachialis. Well, that muscle is telling you what its origin and what its insertion is. Coraco, the coracoid process, is the origin of the muscle. And coracobrachialis, the brachium, or the mid-humerus, is where it inserts into. So again, more terminology that you need to understand. So the humerus is the same as the brachium. The antebrachium is the forearm, made up of the radius and the ulna. The carpus is known as the wrist. So the carpal bones are the wrist bones. So the humerus itself, the humerus bone, this will be a bone that will be on your practical. The bone will be on the table. All you'll have to do is tell me it's the humerus, and you would be right. And we go on. But on my exams, you're going to need to know all the parts of it and all the muscles that attach to them. So on the proximal end, we have the head of the humerus. The head of the humerus articulates with the glenoid cavity. Right next to the head of the humerus is the greater tubercle. The greater tubercle is an important attachment point for muscle. Right below that is the lesser tubercle. The lesser tubercle also is an important attachment point for muscle. So the greater tubercle, if you remember when I spoke about the rotator cuff muscles, well, 3 of the rotator cuff muscles sit on the greater tubercle: supraspinatus, infraspinatus, and teres minor. Then on the lesser tubercle, we have the other rotator cuff muscle, subscapularis. In between the tubercles, we have a canal. Canal is also known as a sulcus. All right, this area right here is a canal, a sulcus, also known as a groove. I know a lot of words for one area, but that is known as the intertubercular groove between the tubercles. You will also hear it as the bicipital groove because it is within this groove that the long head of the biceps come through. Now, some important muscles also insert into this groove. Remember, I said pec major inserts into this groove, and that large muscle on your back, that expansive muscle, also inserts into the groove, the latissimus dorsi. Very important muscle, very important landmark. Right below that is the insertion for the deltoid tuberosity. So those are the landmarks you'll need to know for the proximal humerus. Well, the distal humerus is an area basically for the elbow, right here. This is connecting to the elbow that you're going to need to know. So let's look at this pulley-like thing down here at the bottom. This area right here that's in whitish. Well, this here is on the lateral side, and I know it's lateral because the glenohumeral head is medial. All right, the glenohumeral head is going to be going medially. Well, here's the lateral portion. Well, the capitulum is this area right here, and the capitulum articulates with the radius bone. And here's the trochlea. Remember, the ulna has something known as a trochlear notch. So it's the trochlea that articulates with the ulna. So at the distal end, we have this pulley-like system where the capitulum articulates with the radius and the trochlea articulates with the ulna. On the sides here are the medial and lateral epicondyles. Right here is the medial epicondyle. Again, medial epicondyle, I can tell because it's on the humeral side, which means the other side is the lateral epicondyle. These epicondyles are very important insertion points for muscles. On the medial epicondyle, that's known as the common flexor tendon. And the lateral epicondyle is known as the common extensor tendon that extend the wrist, extend the fingers, and flex the wrist and flexes the fingers. Right above the epicondyles are supracondylar ridges. Supra meaning above, condylar meaning condyle. So we have the medial and lateral epicondyle, and then we have the supracondylar ridges. Those are important because important muscles have origins on there. So again, at the distal end, the capitulum is on the lateral side, articulates with the radius. The trochlea is on the medial end, articulates with the ulna. Right above that, we have the medial and lateral epicondyles. And right above that, we have the medial and lateral supracondylar ridges. The bone on the right is a posterior view. Give me a second here. This area right here is a posterior view of the humerus bone. As you can see, there is only one pit on the posterior side where there are 2 pits on the medial side. So on the anterior side, I'm sorry. So above the capitulum is the radial fossa. Remember, I said the capitulum articulates with the radius bone. Well, this little pit is for the head of the radius. Right above the trochlea is the coronoid fossa. Remember, on the top of the ulna, there on the ulna, on the tip, there is a coronoid process. The coronoid process of the ulna articulates with the coronoid fossa. On the posterior side, we have an olecranon fossa, where the olecranon process of the ulna articulates with. So these are the important landmarks of the humerus that you're going to need to know. Second. Again, there are a great number of muscles that are on the humerus. Remember, so I talked about the bicipital groove or the intertubercular sulcus. The biceps brachii goes through there, latissimus and pectoralis. Deltoid tuberosity, that's easy, thankfully, deltoid tuberosity, deltoid muscle. Remember, I talked about the greater tubercle has 3 of the rotator cuff muscles, supraspinatus, infraspinatus, and teres minor. Remember, I said the lateral epicondyle is a common extensor tendon area. Notice all of the extensors on there: extensor carpi radialis longus, extensor carpi ulnaris. Anconius is an extensor of the elbow. When we're looking at the medial epicondyle, that's more of the common flexor tendon, flexor carpi radialis, flexor carpi ulnaris, flexor digitorum superficialis. So again, these bones are important landmarks and important areas where a great deal of muscles have origins and insertions. The radius bone, all right, the radius bone on its proximal end up here, here's the proximal end has a head, has a round head of the radius. Remember, it's the head of the radius that articulates with the capitulum. This bone has a small projection here, known as the radial tuberosity, and it's at the radial tuberosity where the biceps has its insertion point. At the end of the radius, it has a radial styloid process. Again, the radius bone is on your thumb side. The radius bone is on your thumb side. So you'll be able to feel that radial styloid process. So those are the important landmarks you need to know. You'll need to know what the radius looks like. It has the head of the radius. It has the radial tuberosity. It has the styloid process of the radius. Please understand this. Whenever we pronate and supinate our forearm, the only bone that moves is the radius bone. Let me say it one more time. Whenever we pronate or supinate our forearm, the radius bone is the only bone that moves. The ulnar bone does not move. So here are some of the muscles that are on the radius. At the distal side, the brachioradialis, you will notice the muscles that are on the radius do a lot of pronation and supination. The biceps brachii does supination. Well, the supinator does supination. The 2 pronator muscles, pronator quadratus and pronator teres, are all on the radius bone. So again, it is only the radius that moves. When your hand is in the supinated position or in anatomical position, the radius and the ulnar are parallel to each other, like train tracks. When we pronate our forearm, the radius goes over the ulnar. Ulnar stays where it is. When we're looking at the ulnar bone, what you need to understand is definitely the proximal side. Well, the proximal side is going to tell you that it's the ulnar bone. First of all, it has this circular notch. That's the trochlear notch. On the top, you have the olecranon process, and on the bottom, these two pointy areas, the olecranon process on the top and the coronoid process on the bottom. Remember those fossas that we had? We had the olecranon fossa on the posterior side of the humerus, and we had the coronoid process on the anterior portion of the humerus. So you need to know what this bone looks like. So the ulnar bone has that hook-like trochlear notch. At the bottom of the bone, it too has a styloid process, which is an area that that sticks out a little bit. Remember, your ulnar bone is on your pinky side. Your ulnar bone is on your pinky side. So when you are in anatomic position, your ulnar bone is medial and your radius bone is lateral. As you could see here, there's this area in between the two bones, between the radius and the ulnar. Well, one of the things it does is it keeps these two bones together. But an important aspect of this interosseous membrane is that it transmits forces up to the stronger, bigger bones. When you see these bones in a couple of weeks, they're very, very thin. They're easy to fracture, especially the radius bone. But forces actually go up the interosseous membrane and helps distribute the forces so that hopefully there won't be too much force that will decrease the chance of fracture of these bones. So here are the muscles of the ulnar, all right? As you can see, there are a bunch of them. A lot of extensors, a lot of flexors coming from here. When we talk on the olecranon process, you have the important muscles of the triceps brachii, which does the elbow extension. So again, what I did here was I added these muscles to remind you how important all of these landmarks are, that you're going to have to know all of these things. Of the wrist, the carpal bones, I am going to need you, and this is going to be on your practical. All right. Remember, I said you're going to need to know the bones of the proximal and the distal row. This is from thumb to pinky. The proximal row is this yellow row right here. The yellow row, that is the scaphoid, the lunate, the triquetrum, and the pisiform. The green row is the distal row of carpals. That is the trapezium, the trapezoid, the capitate, and the hamate. That's how you're going to need to know these bones. Now, if you get them and they're not in order, I am fine with it. All right, so don't freak out. All right, sometimes people learn it in different ways. I have no problem with it. But here is the thing. You're going to have to know where the thumb carpals are. Because when we're talking about when somebody falls on an outstretched hand, certain bones fracture. Scaphoid and the lunate are the ones that fracture and dislocate the easiest. That's why I like starting it from the thumb, because it's much easier with all the other information that you need to know. So again, you need to know the proximal row is the scaphoid, the lunate, the triquetrum, and the pisiform. The distal row is the trapezium, the trapezoid, the capitate, and the hamate. So when we're talking about sesamoid bones, we have two in our body, two major ones that you need to know. In the wrist, the pisiform, and in the knee, the patella. Those are your two bones that are within the tendons of muscle. The metacarpals. So again, I'm going to want you to know the joints of these bones. So the joint between the carpals and the metacarpals is the metacarpal phalangeal joint, the MCP. The metacarpals and the phalanges. So this is, I'm sorry, my apologies. This is the metacarpal joint, carpal, metacarpal. This is the CMC right here. My apologies. CMC. The MCP is right here. MCP is your knuckles. This joint, set of joints right here, is the PIP, the proximal interphalangeal joint. And this one up here is your distal interphalangeal joint. Remember, flexor digitorum superficialis only goes to here. Superficialis only flexes this far of the finger, but flexor digitorum profundus flexes these parts of the finger right here, flexes the distal part of the finger. So that's important information too. All right, so those are the joints of the fingers, the joint of the hand. All right. So here are some of the muscles of the wrist and the fingers. If you look on the bottom, so we're talking about the phalanges of the hand or the fingers. Again, flexor digitorum superficialis flexes the middle phalanges, flexor digitorum profundus flexes the distal phalanges, and extensor digitorum extends digits 2 through 5. So these are all important muscles, and I've got their inserts like, so these are the muscles on top here that insert onto the first metacarpal, then the second metacarpal, the third, and the fifth metacarpal. Here's what the pelvic girdle looks like. I might have a bony structure that looks like that, but we'll go over it. This is how the hip bone, how I'm going to present the hip bone to you guys. There are 3 parts to the hip bone. All right. So the first part is the ilium. That's this part in tan. The ilium is the superior portion. And it's actually kind of broken up. The acetabulum is broken up into these parts. So the tan part right here is the ilium portion. The bluish green portion back here is the ischium. And the pink portion right here is the pubic portion. Now, each of those portions have different landmarks that you're going to need to know. At the top is the iliac crest. So the top of the bone, the superior portion, is known as the iliac crest. This area here, this browned area that basically has all 3 parts, is known as the acetabulum. That is where the head of the femur attaches to. And finally, this hole right here is known as the obturator foramen. And it's that area where the piriformis kind of comes out from the anterior sacrum and goes and attaches onto the femur itself. Now, the more important landmark. So let's look at the anterior side. So here is the anterior side of the bone right here. On the anterior side, we have the ASIS and the AIIS. Important landmarks because sartorius comes from the ASIS and the rectus femoris comes from the AIIS. On the posterior side, we have the posterior superior iliac spine, PSIS, and we have the PIIS. What we also have is the greater sciatic notch, the greater sciatic notch, and the lesser sciatic notch. So the greater sciatic notch is in the ilium, the lesser sciatic notch is in the ischium. More important part of the ischium is this part right here, the part that we sit on. That is known as the ischial tuberosity. You need to know the ischial tuberosity. It is, when you're looking at the bone, it's a rough spot, a rough area on the bone, because it's also an area of muscle attachment. And finally, this area in pink, right here is the body of the pubis. That's where the pubic symphysis comes into play. Okay? So the important parts of the hip bone, the iliac crest, the acetabulum, the obturator foramen. You need to know the ilium portion, the ischium portion, and the pubis portion. And I'm definitely much more interested in the ilium and the ischium. When you're looking at the ilium, you have the ASIS and the AIIS on the anterior side, the PSIS and the PIIS on the posterior side. You have the greater sciatic notch. On the ischial portion, you have the ischial tuberosity, you have the lesser sciatic notch. And finally, on the pubis, you have the body of the pubis. Those are all the important aspects that you're going to need to know for this hip bone. And as you can see, there are a lot of muscles that attach to this hip bone. All right, a lot of muscles that attach to this hip bone. Okay, so you're going to need to know a lot of them. The femur, well, the femur articulates with the hip, creating that ball and socket joint between the head of the femur and the acetabulum. Okay, this is the longest and strongest bone of the body. All right, the head of the femur forms a ball and socket joint, and on the top, on the very top of the bone, there is a small hole here known as a fovea that allows for a ligament to attach and allows for the needs of the bone in the acetabulum, so nutrition to get to that area. So here is the head of the femur. The head of the femur articulates with the acetabulum. There is a greater trochanter. There is a lesser trochanter. If you see on the slide before, you will see the muscles that attach to the greater and lesser trochanters. In between, there is an intertrochanteric line or an intertrochanteric crest. Okay, so again, between trochanteric trochanters. Remember, on the proximal side, we have the greater trochanter and the lesser trochanter. On the posterior portion of the femur, we have this ridge-looking area. This ridge-looking area is known as the linea aspera, and this is an attachment point for muscles. Okay, so the linea aspera. Let me come out. If we go down to the distal end of the femur, on the bottom here, this area here and this area here are known as the medial and lateral condyles. The medial and lateral condyles of the femur articulate with the medial and lateral condyles of the tibia. They articulate with each other. Right above the condyles are epicondyles. You have a medial and lateral epicondyle. Okay? And above that, you have a medial and lateral supracondylar ridges or supracondylar lines. So you got condyles, you got epicondyles, you got supracondyles. This area right here is an area of smoothness that articulates with the patella right here. All right, that's the patella. Patella, again, is a sesamoid bone because it sits in the patellar ligament, which is created from the quadriceps tendon. So here are some of the muscles on the femur. All right, so again, on the femur, we have a lot of adductor muscles. All right, on the front, we have the vastus muscles. All right, on the greater trochanter, we have some of the gluteus muscles. So very specific areas for a lot of big muscles. Here's the patella. You're going to, so again, on your practical, the patella, sorry, somebody asked a question. Oh yeah, that's fine, Ashley. That's fine. We'll talk to you later. So with the patella on your practical, this is what it'll look like on the table. You'll just have to say it's the patella. But on the quizzes, if I put a picture of it, I might ask you which one is the base part and which one's the apex part. Now, this is what the patella looks like when it's articulating with the femur. It looks just like this. Looks just like this. So here's the problem. When I hear base, I think of bottom. Well, the problem with that is this on the top is the base. I don't make this up, guys. This is not me. All right, I don't make this stuff up. So the base is the top portion of the patella. It's the broad superior portion. And the apex, well, apex means point. So I'm good with that. But whenever I hear a point, I think of the top. Okay? In this case, so what I want you to think about is the patella is backwards. The patella is backwards. The base is on the top, the apex is on the bottom. The apex is the pointed inferior part of the bone. Please understand this. This is going to be on your quiz. All right? And the reason is because we do something known as patella mobilizations. So we have to understand the patella. I know it's a small little bone, but we do a lot of work with it. And it has a lot to do with the way we walk. So again, the base is on the top. The apex is on the bottom. All right. It is confusing. I have no argument with you there, but I didn't make it up. And again, this is a sesamoid bone. It is within the quadriceps tendon or the patellar ligament. The tibia, very thick weight-bearing bone. All right, very thick weight-bearing bone. All right, so the tibia is this bone here. Let me take a picture. Let me get a picture. Move it back. There's my tibia. Here's the tibia right here, the big, thick bone. The fibula is always laterally. It's always the lateral bone. The tibia is always the medial bone. Very important to know that. Tibia is medial, femur is lateral. So, talk about the proximal portion first. On the top portion, we have the medial and lateral condyles. Remember, that's where the femur, the medial and lateral condyles of the femur articulate with the medial and lateral condyles of the tibia. In between these condyles is something known as an intercondylar eminence. Again, between condyles. But they call this an eminence. It looks like a mountain range. Well, the intercondylar eminence is where the ACL and PCL ligaments attach. Very important area. Okay, so we have the condyles of the tibia that articulate with the condyles of the femur. In between, we have the intercondylar eminence, which is a mountain-like looking structure where the ACL and PCL attach. On the anterior portion of, right here on the anterior portion of the tibia is the tibial tuberosity. The tibial tuberosity is directly in the middle. It is the insertion point for the quadriceps muscle, for the quadriceps / patella tendon. That's where it attaches to. An important part that is not on here, and I'm going to point to this area right here, that is the anterior proximal medial portion of the tibia. And it is this portion that is known as the pes anserine. The pes anserine is an important portion of the tibia because 3 muscles attach to that portion: the gracilis, the sartorius, and the semitendinosus. On the distal end of the tibia is the medial malleolus. Remember I said the tibia is on the medial side, the fibula is on the lateral side. So if you reach down for your ankle bone on the medial side, that is the distal portion of the tibia. The medial malleolus is part of the tibia. This, that. These are the muscles on the tibia. As you can see, there are a lot of them. You're going to need to know them. The fibula is on the lateral side. This is a lateral strut. It's a stabilizer of the ankle. This bone has no weight-bearing function. This bone fractures very easily. All right. The head of the fibula is the proximal end. The apex has a point, and that is the lateral malleolus. Remember, I just said the medial malleolus is the tibia. The lateral malleolus is the fibula. As you can see, there's a good number of muscles that attach to the fibula. So it's a very important bony structure. All right. Remember, I said when we spoke about muscles that we have the fibularis or peroneus muscles. Remember, I said it's going to be much easier for you to remember the fibularis because it's part of that muscle, part of that name is telling you where it's coming from. Peroneus isn't really telling you anything. What I need you to know is that the fibularis / peroneus muscles, they correlate to each other. Easy to remember fibularis because you know where it's coming from. It's coming from the fibula. The ankle bones, well, what I need you to know about this, I need you to know the important parts of it, of the ankle. So right here on the top, looks like a pulley. This is known as the talus. This is the most superior tarsal bone. The talus articulates with the medial and lateral malleolus, creating the ankle joint. It is the talus, all right, with the medial and lateral malleolus, or the tibia, the distal end of the tibia and fibula, that create the ankle joint. Right below the talus is the calcaneus, that big, thick bone, also known as your heel, all right? And it's on the calcaneus that the Achilles tendon attaches to. As we go along towards the foot, after the talus, we have a bone known as the navicular bone. The navicular bone is on the medial side, and with the navicular bone, you can actually palpate the navicular tuberosity, which is a bone that sticks out from there. Right above the navicular is the medial cuneiform, and we have a medial, an intermediate, and a lateral cuneiform. That's these three bones. So again, this is the medial side, and I know it's the medial side because here's the big toe right there. The big toe is always on the medial side. So the navicular is always on the medial side. The next bone up, distal, is the medial cuneiform. And then as we go across, we have intermediate and lateral cuneiform. And finally, on the lateral side, we have the cuboid bone. These long bones here are the metatarsals. Remember, we had metacarpals in the hand. In the foot, we have metatarsals. Okay? Those are the long bones. I will not ask you any questions on those long bones. Okay? So the bones I'm going to need you to know is the talus. I'm going to need you to know the calcaneus, the navicular, and there's a couple more here that I'm going to go through. These are the muscles of the foot that you're going to need to know. Now, these two pictures are probably pictures I'm going to use on your quizzes. This is a medial view of the foot. So again, when we're talking about the medial, we're talking about the medial side. Here is the trochlea on the top. Remember, the trochlea articulates, the trochlea is the top of the talus, and the trochlea articulates and the talus articulate with the medial and lateral malleoli. Right here on the bottom is the calcaneus, the big heel bone, right, where the Achilles tendon attaches to. Now, a bone that we have not talked about that I do want to talk about is this bone in between. And you'll be able to picture that bone when we get on campus. The bone in between is known as the sustentaculum talus. Sustentaculum talus. The job of this bone is to stabilize the talus on the calcaneus. It's to maintain the talus on the calcaneus. Remember, I said the next bone after the talus is the navicular bone. And there's this portion of the navicular bone that sticks out that you'll be able to palpate. That is known as the navicular bone, the navicular tuberosity. Just distal to that bone is the medial cuneiform. And then you got the first metatarsal, the first long bone. That's the medial side. You'll notice that you will not be able to palpate the intermediate or the lateral cuneiform from the medial side, nor can you see the cuboid bone from the medial side. So let's look at the lateral side of the bone, a lateral side of the foot. So from the lateral side, you'll be able to see the calcaneus right here. Sorry. This is the ending, so we're almost there. So let me get my... So here's the calcaneus right here. This is the lateral side. The next bone after the calcaneus is the cuboid. Cuboid, think of a cube. It's four-sided. That's what it looks like. From this side, you can actually see the intermediate, these two cuneiforms right here, the intermediate and the lateral cuneiform, but you won't be able to see the medial cuneiform. And you'll be able to see the metatarsals 2 through 5 right here. So on the lateral view, you can see the cuboid the intermediate and lateral cuneiforms pretty well. All right. So we'll have that picture, and I know this hasn't been given to you guys yet, but it will be on Blackboard when we get on campus. So that is the bones. All right. That is all the bones and the bones that's going to be on your practical. So when you have your, when you're studying it, I would study them as the ones that I need to know for my practical, but you need to know the landmarks also. You have to know the landmarks, okay? Because it's going to be on the quiz. So I would start studying them together, all right? Again, the scapula, very, very important bony, bone that we do a lot of work on. So, John Carlos, any questions, sir?
Actually, yeah, for the foot, we only have to know the calcaneus, the talus, and the navicular, right?
You'll also need to know the
Practical.
sustentaculum talus. So the talus, the calcaneus, the sustentaculum talus, which is the bone that stabilizes the talus, the navicular bone, that's on the medial side, and the medial cuneiform. On the lateral side, you'll need to know the cuboid, the intermediate and lateral cuneiforms, and that's it.
All right. Sounds good. Thank you.
You're welcome. All right. I'll be sending this video out to everybody. I'll also be sending out the updated books. They sent me the updated book list. So the dean sent us something to remind you guys to really start thinking about purchasing those books, because it seems like Amazon and everybody is kind of backed up because of Christmas. Why would that be? And because of the delivery of the vaccines also. So everybody is kind of backed up. So if you guys can get your books as soon as possible, I would get them, and I will write notes on that email telling you guys what is really required and what I recommend. All right.
I ended up ordering already the trail guide book,
Excellent.
and then the flashcards, and also the PTA exam.
Yes. The Giles book is a required book. I will actually be on day one. I'll be giving you like a table of contents for the intro class on what pages you are to go to for whatever chapters we are studying. So I've already done the work for you guys. All you got to do is go to it. So, all right.
All right. Thank you.
Good.
Have a nice day.
I'm glad you got that stuff. That's good.
Yeah.
Just, get going with the bones and the muscles, and you'll be ahead of the game.
All right. Sounds good.
All right, sir. You have a very wonderful evening. Stay safe and stay healthy.
Thank you, you too.
All right. Everybody have a good evening.